So this is a 30-year-old female with a history of ankle sprain from a previous injury, and then noticed a lump which got progressively larger. If we look at the couple CT examinations, we can see a soft tissue mass medial to the ankle, and we can see it's kind of surrounding the medial tendon there, or the posterior tibialis tendon. This is much better seen on various MR sequences. The axial images show the mass quite nicely, and hopefully you can appreciate the posterior tibialis tendon that this mass is surrounding, and that the mass is fairly low signal on our water sensitive sequences, at least the non-fat suppressed sequences. I think this is similarly well shown here, where we see the mass medial to the ankle. And again, you can see the darker posterior tibialis tendon within this mass also. And on standard T2 weighted images, intermediate signal at most. And we can see the same thing on our other sequences as is circled here. And here we're marching from proximal to distal, so you can see the length of this process surrounding the posterior tibialis tendon also in this case. And all of these axials just show the same thing as we're marching from superior to inferior, this mass surrounding the posterior tibialis tendon. You can note that there's no hindfoot valgus deformity, so it doesn't look like there's any posterior tibialis tendon dysfunction. If we look at sagittal images, we can see the same thing and really nicely appreciate the length of this abnormality, and again, that low to intermediate signal on our water sensitive sequences. Quite important to look at the extent, and we'll see that in just a little bit with the intraoperative pictures. And again, there is the posterior tibialis tendon surrounded by this mass. Here are the intraoperative pictures, and notice us telling them the length of this abnormality tells them how much of a fillet they're going to have to do, because a lot of times this disease is very focal and localized, and wouldn't have to do this big of an incision, but really vital for us to tell them the length of this abnormality, because that determines the length of their incision. And so there you see the brownish discoloration of this long mass surrounding the posterior tibialis tendon. Here they're delivering this bouncing baby mass out, and you can see them pulling the posterior tibialis tendon away with the rongeur as well. So there is the mass, and there it is out, and you can see the brownish discoloration of this mass. Now, after they have it resected, you can see the posterior tibialis tendon here. I don't know if you can see my arrow, and that would be the flexor digitorum immediately behind it, as we can see here. And so just a match of before I'm taking it out and after I've taken the entire thing out. If we look at the histology, we can see some foam cell areas, which are pretty common in this disease. And then if we look at higher power, we can see the multinucleated giant cells and then all the mononuclear cells as the background. And a lot of people believe the cells are engulfing those mononuclear cells, and that's what's creating the multinucleated giant cell. On this image, we can see villonodular morphology within the tenosynovial tissues, and all that brown is hemosiderin deposition, really nicely shown here, predominantly intracellular, although it can be extracellular as well. So here, just a compilation of all of our images shown here and matched with the gross specimen as well in this case. And so this is localized giant cell tumor of tendon sheath, or tenosynovial giant cell tumor, formerly known as pigmented villonodular synovitis, and given to us by Dr. Brian Slavonik from Elmira, New York, from Arnaud Ogden Medical Center. So we thank him so much for this wonderful case. And I know I showed it when I was lecturing on this on Wednesday as well. So thanks very much.
Thank you, Dr. Murphy. All right, for lots of great cases, I did have to pick one. So once again, thank everybody for submitting. All right, so clinically, we have a 53-year-old female who presented to her primary care physician due to left nipple swelling and discoloration. Patient denied nipple discharge. She denied fevers, chills. She had a history of a left lumpectomy for stage 1A disease and invasive ductal carcinoma with sentinel lymph node biopsy 12 years ago. She was a good patient. She completed her adjuvant radiation therapy and endocrine therapy after her surgery. All right, here she is on physical exam, and she had an enlarged nipple. It was swollen. There was thickening of the nipple areolar complex. You can also see kind of this reddish purple discoloration. Also on physical exam, there was about 6 centimeters of firmness in this retroareolar region. So just looking at the imaging here, I know as radiologists, we're so used to looking at pictures, but sometimes we forget to go look at the patient. Is this infection? Could this be a reactive dermatitis due to trauma? Maybe this is a bruise. And the patient's just embarrassed to say how she got the bruise. However, this skin discoloration was not resolving. Could this be a recurrence of her prior breast cancer with some locally advanced changes, or perhaps even a new primary? All right, we have a MLO view of that left breast, and here are some surgical clips. This is her prior lumpectomy site. You can see diffuse skin thickening here, especially anteriorly, along with that nipple areolar complex. There's some increase of the trabecular markings. Could this all be due to her previous radiation therapy? There weren't any priors for comparison. So what are you going to do next? It could be any of those possibilities in that differential. So do an ultrasound. Go to your toolbox. Patient underwent an ultrasound. There was thickening of that nipple areolar complex, a little heterogeneous in appearance. Also, there was this heterogeneous non-mass region on ultrasound in that subareolar region. On MRI, here's the T1 post-contrast subtracted image in a sagittal projection. We can see, and this is just in a large image of this view here, we have that enlarged nipple with skin thickening and all this abnormal enhancement of the skin. And then immediately in that retroareolar region, we have this 6 centimeter heterogeneous enhancing mass with a little non-mass enhancement as well. On the patient's PET scan, you can see that skin thickening, that retroareolar mass. There was no adenopathy. This lesion is very FDG avid. On histology, this is a low power view of the nipple. We have these bluish cells infiltrating into both the dermis and epidermis. Here's a high power of these poorly differentiated blue cells. The cells are trying to make these little slit-like empty little channels. You can see some red blood cells in here as well. Gross pathology, there's a 6 centimeter invasive hemorrhagic mass. Just beautiful rad path correlation between the mammogram, the MR, the PET, and also with gross. All right, so the diagnosis is post-radiation, also known as secondary angiosarcoma of the breast on histology. These are malignant endothelial cells. They're high grade. They're predominantly dermal based with variable infiltration into the subcutaneous tissue and in breast parenchyma, such as in this case. With the secondary angiosarcomas, they traditionally present with these skin lesions. However, they can present also with a mass, such in this case. These are going to arise in the radiation field, usually 5 to 10 years post XRT. On epidemiology, they're going to be in older patients for these secondary angiosarcomas. Why? The patient had a lumpectomy followed by radiation therapy. This is in contrast to the primary angiosarcomas, younger patients, no history of radiation, and these are going to arise from the breast parenchyma rather than the skin. Imaging for secondary angiosarcomas of the breast can be variable. Treatment is usually surgery followed by chemotherapy. Radiation really has no effect with sarcomas here. Prognosis, not that great. 5-year survival is about 40%. Metastases are going to be hematogenous of lungs, liver, bone, rather than local regional, as with your invasive breast cancer, no special types. So, the post-radiation angiosarcoma of the breast is the best breast case, and it's submitted by Dr. Marianne Bonanno at Brown University, Rhode Island Hospital. Thank you for submitting this fantastic case, and thanks to everyone else who've also submitted wonderful cases.
I'm going to jump into this GU best case, which was put together by Dr. Marco, but he can't be here. And this clinical information. It was a 47-year-old female who came in with vaginal bleeding and pretty profound anemia, as well as some left lower extremity swelling. And so she underwent CT, which we don't have the images from, which showed an enlarged uterus thought to contain multiple fibroids and a DVT in her left external iliac vein extending down into that left lower extremity. And she went on to get an MRI with some selected images shown here. You can see that the myometrium looks diffusely abnormal, and you've got this sort of worm-like, slightly higher T2 signal intensity tissue involving the cervix, but looks like it also involves some of the parauterine tissues. And then if you look at the left pelvic sidewall, you can see some abnormal intermediate T2 signal intensity material that's expanding the left internal iliac vessels. And you can see up higher that there's extension of this intermediate T2 signal intensity tissue into that left adnexa. And as you follow those left pelvic sidewall vessels up, you can see that they're expanded by that material that looks similar in signal intensity to the tumor. And here you can see a little bit higher that extends all the way up to the level of the left common iliac vein. Here you can see both an axial and a post-contrast image, which shows enhancement of the material that's in the vessel, which makes you think that it's tumor thrombus, which you might have expected already, and it enhances similar to the tumor, which you can see out in the left adnexal region. And so when we see a tumor that looks like this with vascular involvement, you might think of intravenous leiomyomatosis versus some sort of low-grade endometrial stromal sarcoma. So she did undergo uterine artery embolization, IVC filter placement, and thrombectomy, and they analyzed the thrombus, which revealed a spindle cell tumor suggestive of a low-grade endometrial stromal sarcoma, which was ER positive. So then she was referred for more definitive surgery and underwent hysterectomy and bilateral salpingo-oophorectomy. And here you can see the gross specimen of the uterus with nice correlation to the imaging. You can see that worm-like growth of tumor throughout the myometrium, but you probably see it the best at the level of the cervix there, where you see the green arrows. On histology, you can kind of see that worm-like growth on low power with a pushing margin. And here you can see it similarly at high power. And so surgical pathology showed low-grade endometrial stromal sarcoma. There was some clinical margin involvement, including the left upper vagina, left perimetrium, and left ovarian vessel. They did send it for next-generation sequencing, much of which was negative with no actionable mutations. And so she underwent treatment with systemic therapy, including letrozole, and radiation has been deferred with close follow-up imaging planned. So here is a collage of images. Again, you can see the correlation between the imaging, the gross, and the histology. Very nice red path correlation on this low-grade endometrial stromal sarcoma submitted by Dora Chen from Vanderbilt University Medical Center in Nashville, Tennessee. Thank you so much, Dr. Chen, for this great case. This was a 69-year-old male who presented with non-specific symptoms, including upper abdominal pain. And so initially he underwent CT imaging. You can see axial and coronal images from a late arterial phase CT. And you can see that he's got this focal enlargement of his pancreas tail with pretty marked late arterial phase enhancement. And there's some loss of the fat plane between the spleen and the adjacent pancreas tail. Also, you see a fairly lobulated margin, kind of a heterogeneous enhancement pattern, and it looks fairly different from the background spleen, which is in the late arterial phase showing that tiger striped enhancement. But the patient did go on to get an MR. You can see a collage of MR images here, and you see that this is intermediate in T2 signal intensity, somewhat similar to the background spleen, but with more areas of heterogeneity and somewhat irregularly shaped, not perfectly round. You can see that there is that heterogeneous enhancement and restricted diffusion. And so the patient went on to get some additional imaging based on the differential diagnosis for that lesion. This is axial and coronal images from a dotatate PET CT. And you can see that there's marked radiotracer uptake in the region of that pancreas tail mass. Similar to the adjacent spleen, there was also a small lesion in the liver, a caudate lesion, which I'm not showing you here. And so because this is so radiotracer avid, it suggests that it has somatostatin receptors, which helps us narrow our differential diagnosis to include what this entity is, a neuroendocrine tumor. And so this patient was deemed a good surgical candidate, underwent distal pancreatectomy and splenectomy. And you can see the appearance of the tumor here with the CT next to it, nice rad path correlation. This was a sort of fleshy, whitish, pink mass. It was adherent to the spleen. And you can see that on the gross specimen, it appears very different from the background splenic tissue. On H&E, you can see this nested architecture to the cells, which is classically described in neuroendocrine tumors. And if we zoom up to higher power, you can again see that nested or trabecular architecture. If we look closely, we can see that salt and pepper chromatin on some of the nuclei, and you see these interspersed thin-walled vessels, which give these tumors their characteristic prominent arterial phase enhancement. This is a nice slide that was put together by Dr. Manning for the last course, showing some other things that might be on your differential diagnosis. One thing I think about in the pancreas tail is an interpancreatic splenule, which is the bottom cases, but you can see that this generally has a very different appearance both on imaging and on gross specimen. You can see it resembles the splenic tissue much more closely. So this turned out to be a pancreatic neuroendocrine tumor. This was a well-differentiated tumor, which generally has a good prognosis. This had a relatively low Ki-67 of 9%. And so the patient will undergo surveillance. And this was submitted by Dr. Eric Sarugi from Cleveland Clinic, Diagnostic Radiology Residency in Cleveland, Ohio. So thank you very much for both of these great cases.
Okay, just like the prior section she's mentioned, this was a very large course with a lot of excellent cases. And it's difficult to pick one sometimes. And we thank you all for your efforts, especially getting the gross and histopathology. Oops, how do I advance here? There we go. So this is a pediatric case, actually an infant case. You can see a 6-month-old who didn't really have symptoms because infants don't do too much, but eat and sleep. This was picked up at a well-child exam where the head circumference was 100th percentile. On a well-child check, they realized the patient had macrocephaly and got an ultrasound followed by an MRI. And the MRI shows why the patient has macrocephaly because of hydrocephalus right here. And what's causing the hydrocephalus? There's a very large mass in the posterior fossa. And one thing I'm going to point out on this T2 and this post-contrast T1 is it's kind of lobulated. Some people describe it as kind of a grape-like appearance, like a cluster of grapes that you eat. That's very characteristic of this tumor. Okay, there we go. As far as differential diagnosis for brain tumors that can happen in infancy, unfortunately, there's many things that can happen in infancy. I've highlighted one in the upper right because of that grape-like appearance on T2 and post-contrast. It makes us think about a very specific kind of medulloblastoma that can happen, particularly in infants. But there's a wide range, right? Teratoma is the most common congenital fetal tumor. There's a bunch of gliomas that can happen, including astrocytomas, choroid plexus tumors. Down here, you have your DIG and DIA that can happen in infants, as the name would suggest. On the right side, below medulloblastoma, I've listed other embryonal tumors. Embryonal tumors are always something you want to think about when you see a hypercellular tumor, something that's T2 dark in a young patient. These guys down here, ATRT and ATMR, generally happen in very young children, usually less than 3, less than 4. Medullos can happen from infancy all the way up until young adulthood. So medulla is a little bit unique among the embryonal tumors in that it can happen at higher ages as well, all the way up into young adults. So this gross pathology picture kind of mirrors what we saw on the MRI, this multinodular grape-like appearance that's very characteristic of this specific type of medulloblastoma. And here is the histopathology. So on the left side, we have a low power H&E. Right now, my arrow is hovering over very blue parts of the slide. That is the extremely hypercellular and also desmoplastic part of the tumor. The only way to know that it's desmoplastic is to do reticulin stain, which I'm not showing you, but they did do it, and this is both hypercellular and desmoplastic. This very blue part out here. And you can kind of see how it's surrounding these cerebellar folia and kind of infiltrating them a little bit. On the right side, on this lower power, sorry, higher power H&E, um, again, I'm hovering over kind of the more desmoplastic hypercellular areas, and we kind of see there's these nodular areas of slightly lower cellularity as well. So desmoplastic, nodular, these are some buzz phrases that were used in histological classifications of medulloblastoma. I'm going to show you some screenshots from the PATH report, um, not because I want you to fall asleep reading a bunch of words, but because can I illustrate how people think about medullos nowadays. This is just looking at the H&E, the microscopic architecture. They talk about hypercellular areas. And at the bottom, you can see they talk about that nodular arrangement of cells. And the nodules contain less cellular areas and are surrounded by more hypercellular desmoplastic areas. Um, and then they go on to do immunohistochemistry, like we do in all tumors nowadays. And what does this tell us? It doesn't tell us about cellular architecture. It tells us about protein expression. We expect medullos, kind of because they come from neuronal precursors, to stain positive for neuronal markers like synaptophysin and NUN, and that's true in this case. We also expect it to retain INI1 expression, because if it had lost INI1 expression, we'd be thinking about a different embryonal tumor, ATRT. And then with a lot of these embryonal tumors, we expect a pretty high Ki67, as we see in this case, because of very high mitotic activity. So the diagnosis, just based off H&E and IHC, immunohistochemistry, was a medulloblastoma. And specifically, they say it's a non-Wnt activated type. We'll go more into this in a little bit, and they'll specify exactly what was activated in this particular medulloblastoma. To take a step back, when it comes to CNS embryonal tumors, medullos are the most common. So it's a prototypical CNS embryonal tumor, accounts for 2/3. You can see right there's medulloblastoma. There's other CNS embryonal tumors that account for the other third, roughly. And what this one turned out to be is a sonic hedgehog activated TP53 wild type medulloblastoma. And when these happen, these are one of the types that can happen in infants. And when they happen in infants, they're sometimes associated with a syndrome, and they actually have a pretty good prognosis. So again, I've highlighted that this is a sonic hedgehog activated medulloblastoma, and it's P53 wild type. P53 mutants are much worse prognosis. This is the better prognosis, and it's associated with this kind of desmoplastic nodular histologies. So what I've boxed here, this SHs activate TP53 wild type associated with desmoplastic nodular, is also associated with this guy here. That's the one that we can often see in infants associated with a particular syndrome that we'll get into, this medulloblastoma with extensive nodularity. So for comparison, this is a figure from an article that I wrote with the prior second chief, Dr. Keller, showing a nice example of a medulloblastoma with extensive nodularity that looks very similar to this case. So again, that grape-like nodularity. And then we see kind of these nodules of hypocellular tumor surrounded by the hypercellular desmoplastic areas, and you see the high Ki67 in the hypercellular area surrounding the nodules. And this actually has a relatively good prognosis, not as good as the Wnt activated medullos, but probably the second best prognosis of all the medulloblastomas. In this particular case, they also did molecular subtyping, and this is the final diagnosis based on that. You can see again, sonic hedgehog activated, P53 wild type, much better prognosis than the P53 mutant. And they identified a patch1 gene mutation in the tumor. And like I've mentioned before, this appearance of this extensive nodularity in the sonic hedgehog group in infants can be associated with particular syndrome. So they recommended genetic testing. And the patient did have a germline mutation of the patch1 gene, PTCH1 gene. And when you have a germline mutation of that gene, a tumor suppressor gene, meaning all your cells in your body have one bad copy of it, you have a syndrome that's described at the top. The nevoid basal cell carcinoma syndrome, also known as Gorlin syndrome. And these patients are predisposed to these kind of medulloblastomas. They're predisposed to basal cell carcinomas. They're predisposed to dural calcifications, to odontokeratosis, odontogenic keratosis of the jaw, a bunch of different abnormalities. But from a neuro perspective, we think mostly of medulloblastomas, OKCs of the jaw, and dural calcifications. So I want to thank Dr. Balke for this very interesting case of a sonic hedgehog activated medulloblastoma in an infant in the setting of Gorlin syndrome due to a PTCH1 germline mutation.
Case Thank you to everyone for all the submissions to the pediatric section. I enjoyed looking at all these cases and for all the interesting cases. This is a 6-year-old female with no significant past medical history who presented with an incidental finding of an anterior mediastinal mass on a CT of the abdomen and pelvis. Patient went on to have an ultrasound of the chest to first look at this mass, which is pretty common in pediatrics, right? We almost always start with ultrasound to evaluate masses, given there's no radiation and no sedation often needed for these pediatric patients. So here's our ultrasound, and we see this heterogeneous lesion with the cystic and solid spaces within it. On the contralateral imaging, we again see the same heterogeneous lesion, cystic and solid areas with the adjacent beating heart along the right aspect of the heart. Here's some still images, again showing that heterogeneous lesion. We have the some cystic spaces within it, and then vascularity within this lesion. Here's the CT, which was followed up. First an axial CT, which again demonstrates this kind of hypodense lesion along the right aspect of the heart. Not significant enhancement, but there is this phlebolith right here, and also a prominent draining vein heading superiorly to the superior vena cava. Similarly, on the coronal imaging, we see the same findings. There's that large prominent vein coming out of the lesion and that phlebolith. Here are the still images. We've got that phlebolith here and that prominent draining vein in this hypodense lesion along the right aspect of the heart. Here is the cut specimen of the redissected mediastinal mass. It's a fibrous, solid, has fibrous and solid portions along with multicystic portions, and then we have this large draining vein heading superiorly from the lesion. Here's the histology, where we have these thick-walled vascular spaces within this mass, along with these prominent adipose tissue with interspersed fibrous tissue. Additionally, this mass was found to be PIK3CA, have a PIK3CA mutation, which is pertinent in this diagnosis. So here's a table from radiology cardiothoracic imaging looking at key characteristics of simple vascular malformations in the chest. And you can see we divide these into high flow lesions and low flow lesions. Low flow lesions include venous malformations and lymphatic malformations, while high flow lesions are arteriovenous malformations and AV fistulas. Our mass really fell into the low flow category and is most consistent with a venous malformation. This is the most common vascular anomaly. Usually present early in life. They do not spontaneously regress. If we had an MRI, we would be looking for a slow flow anomaly with high signal with various enhancement patterns. If it was a dynamic time resolved MRA, there would be absence of arterial enhancement and gradual persistent enhancement on delayed imaging. And there are phleboliths, in our case, which help secure our diagnosis. In 40% of the cases, phleboliths are present, along with that large draining vein. Just to talk briefly about PIK3CA mutations. This is an oncogenic mutation. As you can see here in this diagram below, during this mutation, during the early stages, and late stages during childhood, right, there's isolated lymphatic malformations and venous malformations. But in adulthood, this leads to cancer. 20 to 25% of colon cancers or rectal cancers, along with breast, ovarian, and lung cancers. Why does this occur? Well, there's this hyperproliferation of endothelial cells, and that's what's believed to cause these venous and lymphatic vascular malformations. The imaging findings are similar to developmental vascular malformations. And remember that, identifying this PIK3CA mutation can lead to treatments. So I'd like to congratulate Megan Kwan. This is a low-flow venous malformation. Thank you, Megan Kwan, for submitting this case. Megan Kwan is from the David Geffen School of Medicine in UCLA and the Mattel Children's Hospital in Los Angeles, California. Congratulations for the submission of the winning pediatric case. Finally, I just want to show the pathology and imaging findings together, including the cut specimen, which shows that large draining vein along with these cystic spaces and vascular spaces, the CT image showing the phlebolith and large draining vein, along with the ultrasound that shows this heterogeneous mass with vascularity, and finally the histology, which has this areas of fat and fibrous tissues along with these thick-walled vascular structures. So congratulations to the pediatric winner, and I hope everyone enjoyed the course.
All right, so let's talk about this cardiothoracic best case. I'm John Lichtenberger. I've met all you guys, I think. Let's see. I have the chat open, but no, I don't. I guess we're not going to do that during the best case. So let's get to it. So Dr. Fraser is unable to be here today. She chose this case and did the slides, and I'm happy to talk about it. It's an interesting case. So this is a 38-year-old with 2 weeks of non-productive cough, fevers, and chills, not responsive to antibiotics. And digging further in the history is recurrent pneumonias, and then some evidence of bronchiectasis on prior imaging. On our CTs, the CTs that came through with this case, this image on your left is a MIT image. I'm sure you are very familiar with these MIT images, but we're looking at a lot of lung parenchyma all at once. You can see this region of consolidation in the right lower lobe. Now, there are airways associated with that inside that lesion, and these airways are too dilated to be in this location, so they're bronchiectatic. You might wonder, well, these airways are very clustered together. Doesn't that mean that we've lost volume? Shouldn't we begin with scarring or atelectasis? What I will say is not shown on these images is this person has a history of tuberculosis. So in the right apex, they've lost a lot of volume up top. So then down here, they also have a little bit of volume loss, but maybe not as much as you would expect. So consolidative opacity with bronchiectasis, and as we discussed earlier in the course, bronchiectasis should raise your concern for a chronic or recurring process. This kind of airway dilation can happen in the acute lung injury phase associated with the clinical manifestation of ARDS. However, in this case where we see these airways dilated over multiple scans, we really should be thinking about a chronic process here. So chronic intermittent obstruction. Here on the sagittal CT, we see the same consolidative opacity in the right lower lobe. On bronchoscopy, we have a very dramatic filling defect within the airway. It looks fibrinous and white within the airway. And this is associated and referred to as a bronchial cast. And the whole diagnosis, when people are expectorating or coughing up these bronchial casts, they're coughing up these branching fine white structures that usually has to do with something filling the airway and forming a cast. So we refer to that as plastic bronchitis, which is where you're forming these casts within the airways themselves, and that's what that would look like. Now, within that larger category of someone is coughing up these branching things that were basically casts of the airways, we have a subcategory, and that one is characterized as having a lot of eosinophils within it that degenerate. Here you can see some of those eosinophils kind of falling apart, and then these Charcot-Leyden crystals. These are beautiful. Look at these polyhedral pink crystals. That happens when the eosinophils have basically dissolved, and what's left of them have kind of formed together and packed together in these crystals. Very characteristic and seen in people with chronic airways inflammation, usually asthmatic. If we refer to this, we have a plastic bronchitis characterized by eosinophils, then our overarching diagnosis is eosinophilic plastic bronchitis, which is usually a disease of childhood, usually in asthmatics, in those patients with chronic airways inflammation. So here to put this case together in this correlate, we have airways, some of which are impacted, what appears to be dilated airways, suggesting some degree of chronicity with consolidation. So a recurrent pneumonia in a portion of lung with airways obstruction, and that corresponds to these eosinophilic casts and plugs within the airway. So eosinophilic plastic bronchitis, what I would take away from this case is very rare. Only a few cases have been reported. But as a practicing clinical radiologist, what I would take away is to pay attention to the airways for bronchiectasis, which tells you that while they may have a pneumonia, they also have something chronic going on that may be leading to a recurrent pneumonia. And then I would take a second look at things filling the airways. In those cases of chronic airways disease and pneumonia, I would look for things filling the airway that would lead them more toward a bronch, in which case they would make this diagnosis of eosinophilic plastic bronchitis. So thank you so much to Christina. We appreciate you bringing this case, a beautiful bronchoscopic image. Thank you.